I think this is something that of all of the 8 different pulmonary toxicities you and I have talked about over these 2 different podcasts, they're all very different etiologies and treatments. So we went everywhere from infection and good stewardship with antibiotics to pulmonary GVHD to diffuse alveolar hemorrhage. And I think that's what's the hardest part for us as nurses is it's not just one thing that's causing it, and there's multiple different ways to treat these things.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Beth Sandy, Thoracic Medical Oncology Nurse Practitioner at the Abramson Cancer Center at the University of Pennsylvania in Philadelphia, about pulmonary toxicities in patients with cancer. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. In a previous episode, which we've linked in the description, we have spoken about a few other pulmonary toxicities: pulmonary embolism, pneumonitis, and pleural effusion. So Beth, thank you so much for coming back to join us again to talk about a few more.
Thanks, Jaime. Thanks for having me. It's funny because there's so many different ones. We really couldn't put it all in one. So I'm happy for you to have me back so we can talk about some of the others that I think are important as well.
Well, let's just get to it. So let's start off with radiation toxicities. We know one of those potential toxicities is radiation pneumonitis. Could you give us a brief overview of how this type of pneumonitis occurs? Maybe what is the typical timeline of presentation?
Anytime that you're going to have radiation either to the lungs or to an organ that is adjacent to the lungs, the lungs are going to absorb some of that radiation dose, whether intended or not intended. So my background, of course, is lung cancer. So obviously we're intending to hit the lungs with radiation. But, we also sometimes forget about things like breast cancer or lymphoma, where you're getting radiation to the chest for the lymph nodes, because the lung is going to absorb some of that radiation dose as well. So when the lungs are having radiation, like I said, whether indirectly or directly, they're going to be vulnerable to some scarring and inflammatory changes. And radiation pneumonitis in itself is going to be an inflammation of the lung tissue. And we know that pneumonitis in itself occurs for many different reasons, but in this case, it would be specific to the actual radiation.
I was just going to think about that as that, pneumonitis is not unique to only radiation. Certainly we see that in certain chemotherapies, more often now with certain immunotherapies. And so interesting, but important to realize that especially whatever your patient is receiving in terms of their treatment plan and their diagnosis, that the risk for pneumonitis could potentially be coming from multiple different angles. Can you talk a little bit about in radiation specifically, are there certain types of techniques or modalities of radiation that make it more likely?
Sure. So if anything, our more modern techniques make it less likely, which is awesome. Things like IMRT. So IMRT is a type of radiation that can really take into account certain movements. And this is particularly important with the lungs because we can't necessarily have patients hold their breath for a long period of time. So the chest rises and falls and the heart beats while you're trying to do radiation to the lungs. So with IMRT, they can simulate that so that the beam is going to follow that specific movement in the patient. That's really helpful because then hopefully we're going to keep that radiation dose mostly on cancer tissue and not on healthy tissue. And thus that should reduce the amount of radiation that's to the healthy tissue and hopefully reduce pneumonitis. Another technique as well is SBRT or stereotactic body radiation. So instead of doing a wide or a large field, if you have a small pinpointed area, let's say a 1 centimeter tumor in the lungs that's fairly peripheral, but the patient maybe is not a good surgery candidate or has already had surgery and we don't want to take another whole lobe of the lung out. We can do this very high dose, yet to a very small area, stereotactic body radiation to the lungs. So there's pros and cons there. The big pro is that, of course, you're hopefully going to really reduce the amount of radiation that's going to go to healthy tissue, and you'll get a nice high dose to that small area. But again, the downsides to this are hopefully it's a small mass. You don't want to do a huge heavy dose of SBRT to something that's large, because then you are certainly going to get healthy lung tissue that's in the way. The other thing is that hopefully it's not close to any vital organs. So we typically will not do SBRT to anything that's centralized, because then you're risking things like the heart and the spinal cord and the esophagus and the trachea, for that matter, that are going to get this high dose of radiation that we want to avoid. But SBRT can reduce the amount of radiation to healthy tissue versus doing a larger field like we typically will do, especially for stage 3 patients with lung cancer. And then the final technique that I was going to say, minimizes radiation pneumonitis is proton beam therapy. Proton beam radiation is something that we've described in the past as radiation that will typically have an entrance dose, but not an exit dose. So minimizing toxicity by hopefully around 50%. So if you can picture a patient lying on a table, that radiation beam has to go in, hit the tumor, and then exit throughout the back of the body in the lungs. Well, if you're doing proton beam therapy, that radiation is designed to only have an entrance dose from either the back or the front or the side, whichever way they're going, but then hopefully stop on a dime at that tumor so that they're only really getting the entrance dose of that radiation that's going to affect healthy tissue, and there won't be that exit dose. So in turn, especially if you're doing that to the lungs, that should minimize dose of radiation to healthy lung tissue.
That's really interesting. Thanks for sharing all those details just about how nuanced it is. It's not all one and the same. Certainly the radiation techniques are all very unique and different. And so it would make sense that the potential, the risk for pneumonitis and sort of how it might present would be similarly different.
I've been doing this for 21 years as a thoracic oncology NP. And I really do think since we've had these newer techniques over the past 20 years, it seems anecdotally, like clinically, I'm seeing less radiation pneumonitis than I used to see back 15 and 20 years ago.
That's great to hear. So in terms of as this presents for patients, is it just shortness of breath that they experience? Or are there any other symptoms that nurses should be watchful for?
It's very typical of any type of pneumonitis, whether it's from chemo or immunotherapy or radiation. Pneumonitis typically is shortness of breath, dry, nagging cough. So they cough, 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 cough. There's not a lot of mucus usually with it. It's a dry, nagging cough. And then hypoxia. Often they are hypoxic as well.
Thank you for clarifying that. So let's talk about treatments. What can we do for patients that end up experiencing pulmonary radiation toxicities like pneumonitis?
Well, before we move on to treatments, I wanted to just go through a few other risk factors. We always think of, chemotherapy or immunotherapy itself can cause pneumonitis, but adding that to radiation can also increase the radiation pneumonitis risk. So I was looking at a breast cancer study that showed that patients with breast cancer who get radiation, and if they're getting Taxol concurrently, that increases the risk of radiation pneumonitis, which I found interesting because, in lung cancer, we use Taxol all the time as our main radiosensitizing drug. So, and I feel that it's very safe to use. So I found that to be of interest. Also, using immunotherapy in close proximity or along with radiation has also been shown to have higher rates of pneumonitis. And that can be really hard to tell if it's from radiation or the immunotherapy. And it's hard to tease that out. There's certainly higher rates than what it would be by itself. And then certain chemotherapy drugs would certainly increase that risk. And, I tried to nail this down to a couple, but actually as I looked, there's anecdotally really stories about almost every chemotherapy drug that has resulted in causing a radiation pneumonitis when used along with radiation. So I think the addition of chemotherapy, immunotherapy, whether before, after, or during, is going to increase your risk of radiation pneumonitis. And then another thing I found interesting is that smoking history is not necessarily a risk factor to increase your risk of radiation pneumonitis. Now, what I'll say is that having COPD or a smoking history, your lungs are already not going to be in the best shape, so the outcomes may be worse. But just the fact that you've smoked in the past doesn't necessarily put you at a higher risk for developing radiation pneumonitis. So I found that to be interesting as well. The other thing I wanted to say is people always say, well, what's the rate of radiation pneumonitis? Like patients ask me this all the time before they start radiation. And I think that's really hard. It's been listed across trials as very, very different. Like, for example, there was an SBRT trial in non-small cell lung cancer that said the rate of radiation pneumonitis was 9% in that trial. If you look at typically the radiation literature, they're going to say around 15%. But then I found it interesting. There's a clinical trial in non-small cell lung cancer that looked at patients who received chemoradiation, and then they go on to get immunotherapy after chemoradiation. And this was a placebo-controlled trial. So in the placebo arm, they said that 25% of patients developed pneumonitis. Well, obviously they weren't getting immunotherapy. They were on the placebo arm. So that would have been from radiation. Now, I think typically on clinical trials, we maybe overcall it a little bit, but I do think the rate of radiation pneumonitis for patients with lung cancer specifically is somewhere in the realm of 15 to 25%.
It's really interesting. You brought up a lot of good points in there about just recognizing in terms of risk factors, and also if patients present with certain symptoms, just trying to kind of tease out what the cause of it is. You cannot forget just underlying respiratory issues that patients bring with them when they get this diagnosis and they start to go through treatments, of just trying to identify, okay, which drugs could cause it? Could radiation cause it? Do they already have lung problems to begin with? Sort of like putting that puzzle together obviously can be very complex.
So you had asked about treatments. So typically steroids, that's not going to surprise you. And pretty much most of these, pulmonary toxicities, corticosteroids is going to generally be what we give these patients. So for radiation pneumonitis, this is going to be a longer term taper. So sort of like we do it with immunotherapy. This is going to be something that we try to taper them over a month. It's not usually a quick taper. If somebody has minor radiation pneumonitis, I might try inhaled steroids first. And then if they don't respond, they become hypoxic or something like that, then move on to the higher dose steroids and do like a long taper. Typically, like I said, like we do in immunotherapy. And I will say it generally does work. It usually is going to knock this out. And I see very little recurrence of it. So that's the good thing.
Wonderful. Well, that's great to hear. As you said, steroids are certainly a mainstay now that we are seeing a lot more of those immune-related adverse events. That steroids being the treatment for a lot of these conditions is becoming more commonplace. So something that hopefully nurses are becoming more familiar with. So let's shift gears a little bit. Now let's pivot to graft versus host disease, GVHD, of the lungs specifically, which we know can be a side effect of certain types of stem cell transplants. Can you tell us a little bit more about what that timeline of presentation looks like and what the differences might be between an acute versus a chronic presentation of GVHD?
Sure, Jamie. Thanks for asking. I mean, this is not my wheelhouse. I'll point that out. I'm a thoracic oncology MP. So I did some homework looking at this, and this is scary. I will tell you, from when I looked this up, I thought, oh my gosh, this is really bad. So when I tried to look up the rates of this, it said this could be anywhere from 20% to 50% of patients post allo stem cell transplant. But listen to this, it accounts for 50% of mortality associated with stem cell transplant. So this is a bad one to have if you're going to have it, it seems like. The acute versus chronic. So acute GVHD would occur acute pulmonary GVHD would occur within the first 120 days. And it appears the median time that it presents itself is around 6 weeks post-transplant. In this study, they said the rate of acute GVHD was about 3 to 15% of patients. And they had a specific term for it. They called it IPS, or interstitial pulmonary syndrome. Now, it appears that in much of the literature, that's kind of synonymous with ILD, or interstitial lung disease, which is more commonly what we call it. But we see it called IPS, this interstitial pulmonary syndrome. The mortality was high in this study that I looked at for acute pulmonary GVHD. The mortality was 60 to 80%. So obviously, this is a really scary thing to have. Now, when I looked up the chronic, this was a little bit different. So this typically happens, post 120 days, even up to 3 years after your transplant. And there's a syndrome here that they call CLAD, C-L-A-D, which is chronic lung allogeneic dysfunction. And again, they say it's kind of a manifestation of GVHD. So it's not like an acute GVHD, but chronically over time, the lung parenchyma develops this dysfunction as a result of, I guess, sort of a chronic GVHD. So this, they reported, can occur in about 20% of patients. And this is one of the biggest barriers to the long-term survivors for patients who have GVHD. The other thing that I'll say that typically this manifests, this clad, as something we call BOS or BOOP. I don't know if you've ever heard of this, but this is like an obstructive. So this is a bronchiolitis obliterans syndrome or a bronchiolitis obliterans obstructive syndrome, where the bronchioles become obstructed and they end up developing a lot of mucus. And this can be very difficult to treat. So the treatment for both of these things is, of course, steroids.
Say it with us.
Yeah. So steroids, of course, but then beyond that, with a pulmonary GVHD, they're often using antibiotics as well, especially when there's the BOS syndrome associated with it. And they're often more likely to add the TNF immunosuppressants as well, those more potent immunosuppressants. I did see in one of the studies, they said, if it's a more of a BOS or BOOP pattern, they will typically use inhaled steroids if the patient is more minimally symptomatic. But then for the more advanced cases, they would go to the systemic steroids, antibiotics, and then onto the more potent TNF immunosuppressants.
Wonderful. Well, thank you, Beth, for that overview. I really appreciate it. I also am not a transplant nurse by training, so that is all very new and scary sounding. But I mean, again, it highlights what we know is that transplant is serious, both leading up to it, the induction that's required to get patients prepared for that, and then monitoring after that. It's a whole different set of things to monitor for. And so for those nurses that work in that specialty, I'm sure that this is something that hopefully they don't see often, but are prepared and monitoring for. But thank you for giving us that overview just so that all of us are aware of it if we do have patients. And, as the condition obviously demonstrates, it happens sometime after transplant. And so I think it is just unique that this sort of is something that's not going to necessarily show during the active parts necessarily of this transplant, but there's that long-term risk of this showing up later. And so it just, I think, highlights again the importance of being vigilant, monitoring for it, making sure patients recognize that while, yes, there is potential for acute presentation, that the chronic and the long-term presentation is equally possible. And so it just reinforces our need to educate our patients and help them stay aware.
I was just completely shocked by the accounting for up to 50% of mortality related to stem cell transplant. That was like, wow.
Yeah. So now let's talk about something a little bit more broad. Infection. Infection obviously is a risk for anyone undergoing cancer treatment that impacts their immune system. We know that's a major risk factor for anybody with cancer. And of those infections, respiratory infections, we'll talk about here, they're spread easily. So what are some common causes of respiratory infections in patients with cancer that nurses should be mindful of and be educating their patients about?
This is, like you said, really a broad category. So we don't have to spend a ton of time on this, but something to say is that for nurses, we should take into account the clinical presentation. So for example, patient comes in, they're short of breath. There's a million different things. I mean, we're on our seventh one in this tandem podcast at this point. So there's so many different things that can be going on. But infection typically or often, what are their blood counts? So if they're short of breath and their blood counts are low, I'm always thinking, okay, could this be infection? Are they febrile? So most of these other things often don't have a fever, but a fever is going to be also a hallmark. Are they producing thick, ugly looking mucus? And I say ugly because patients always say green is the buzzword. And if it's green, it must be infectious, but it doesn't have to be green. It can be dark yellow. It can just be yellow. But if they're having a fever, low blood counts, thick, or like I said, ugly mucus, this often typically can be infection as well. And then get a chest x-ray because, a lot of times I've been saying for a lot of these things, we need a CAT scan to see this. Actually, infection is probably best noted on a chest x-ray because this is something that will consolidate. And then on a chest x-ray, consolidations will show up and radiologists often will be able to say that looks like a consolidation. And a lot of times that could be infection. So when you put the puzzle pieces together, low blood counts, fever, ugly looking mucus, do they have risk factors like they already have obstructive pulmonary disease on top of it? That's going to put them at higher risk for infection. And then radiographically, that chest x-ray. So just really put your clinical judgment here and what are the other scenarios going on. I'll tell you, there's this whole push-pull on, is it viral versus bacterial? And if somebody has a fever, I'm definitely using an antibiotic. Do we always have to give an antibiotic though if a patient comes in and says, hey, I have a cough with mucus? Not necessarily. One of my fellow NPs is married to an infectious disease doctor, and he's constantly on us about good antibiotic stewardship and not using the broadest spectrum antibiotic and not having to pump antibiotics into people all of the time. Now, in oncology, we have a lower threshold.
We're walking a fine line there. Yeah.
Exactly. But that doesn't mean, like, if I have a patient who's, let's say, on a non-myelosuppressive treatment, their counts aren't low, they don't have a fever, you do have to weigh the risks and benefits of constant antibiotic ordering. So this really becomes, clinical scenarios using your judgment and what's best here for the patient.
Wonderful. Thanks for that overview. I think you brought up a lot of great points. And what we would do typically for the average person who does not have cancer and undergoing cancer treatment may not always be the right call for somebody who is undergoing cancer treatment. But as you noted, we know that not all treatments cause that myelosuppression. Where are they in their treatment cycle? Are their counts on the way down? Are their counts on the way up? So it shouldn't be just reflexive. Everybody gets the most potent antibiotic just because we're worried. I think you gave us some of those great examples of why it's important to be intentional and mindful of what we're using and when. But yeah, I think you captured it well that we know infection's sort of a bread and butter thing for nurses just in general. And we're always hypervigilant for patients that we know are undergoing cancer treatment. Febrile neutropenia is something that we're always watchful for. But again, not overreacting either is important. So the last pulmonary complication that we'll talk about on today's podcast is hemorrhage. So what happens and how does it happen, a pulmonary hemorrhage? What causes it?
There's a lot of different things that we can talk about here. Let's do the first one, which seems to be the most obvious, which would be a tumor directly causing hemorrhage. So again, this is my wheelhouse. So patients have lung cancer, and these are often going to be your more centrally located tumors, and they may be directly invading a vessel. They may directly be invading the bronchus, where there's a lot of capillaries or there's a lot of blood vessels that can break and then cause them to cough up blood. You can have tumors or prior treatment that then cause a bronchial fistula that then can cause bleeding. Patients with squamous cell carcinoma of the lung are much more likely to have hemoptysis and pulmonary hemorrhage than patients with adenocarcinoma, though it definitely can happen with adenocarcinoma as well. So I think that's probably the biggest thing is the direct tumor itself can actually just cause bleeding. And then the other thing is certain classes of drugs. So VEGF inhibitors is the big one. When bevacizumab first came out in non-small cell lung cancer, we were very excited. This was before immunotherapy, but there was a very, very clear warning about never giving this drug to patients with squamous cell carcinoma of the lungs because of a very high rate of fatal pulmonary hemorrhage. And then even when given to patients with adenocarcinoma, this can have fatal pulmonary hemorrhage as well. It's much less common. So the risk basically was worth the benefit. But I won't give you all the details, but I had a patient while on treatment with a bevacizumab-based regimen have fatally hemoptysized in my clinic. And it was pretty horrible. It actually happened over in the infusion suite. And this was someone with an adenocarcinoma that had never had hemoptysis before, but developed it while they were there. And even for us, we could not save that person. It happened very quickly. So pulmonary hemorrhage is very difficult and has a very high mortality rate, unfortunately. This is something where I tell my patients, if you are coughing up blood, you need to call us right away. And then a lot of this will end up with an immediate ER referral. Now, if a patient calls in and says, I'm coughing up blood-tinged mucus, I get very specific with them, Jaime. I say, exactly what percentage of what you coughed up is blood? Is it just a streak of blood? Or is it 50-50 blood and mucus? Or is the whole thing blood? And I know it's gross, but I say, send me a picture of it.
Pictures don't lie.
I know, because then I can really see for myself. Because I think some patients will downplay it. And when they send a picture of frank red blood coming out of their mouth, I'm like, you need to go to the ER now. Versus we'll have some patients who will say, I coughed up blood-tinged mucus a couple times this morning, and then it went away and I'm coughing up normal mucus now. And I'll say, okay, we can wait on that. I'm going to get you in to see interventional pulmonary, but it might not be an emergency today. So we need to be very specific when patients say they're coughing up blood to say, how much How much percentage of it is blood? How often did it happen? And did it stop? Because some patients have said, well, I coughed up blood this morning. It was all blood and now it stopped. And I said, well, have you coughed up anything since? And they'll say no. Because what I want to hear is, yes, I've coughed up mucus since and there was no blood in it. So just because they stopped coughing it up doesn't mean they've stopped bleeding. So the thing that usually makes me more confident or more comfortable is if they say, I've continued to cough up mucus, it doesn't have any blood in it. I say, okay, I feel a little bit better. Let's get you in with pulmonary, but it's not emergent. Everything else is usually pretty emergent. The one last thing I'll touch on is diffuse alveolar hemorrhage. And this is something that's pretty rare, but it's really bad. This is 70% of the time fatal. And this is a rare side effect of chemotherapy, and it can happen with many different chemotherapies. It's essentially a reaction that inflames the tiny little capillaries in the alveoli, which are those little bubble type things on the very periphery of your lungs where the gas exchange takes place between oxygen and carbon dioxide. And when the capillaries become inflamed there, you can have just diffuse hemorrhaging, and there's almost no coming back from it. It's terrible. Thank God it's rare, but it is something, that if you see that diagnosed in the ER, that's a really bad thing. Certainly you're never going to give that, whatever treatment they're on, do not ever give it to them again. Kind of the only way to save them is by bronching them and doing like a lavage and trying to clean out that area.
What is the impact of blood counts? Like you mentioned blood counts. Obviously, if someone's platelets are really low, does that make them more likely just to have somewhat not benign, but not panic level hemoptysis that makes you worried for something, a larger event? Do you take that into consideration when you have patients call in with these types of symptoms?
Yeah, that's a really good question. So platelet count on its own. So let's say you have a patient with lung cancer who's never coughed up blood and now they have a platelet count of 10. That doesn't necessarily mean they're going to have hemoptysis. I'm much more concerned about other bleeding from a platelet count of 10. However, if you have a patient who has on and off hemoptysis or a large central tumor, I do not want to get their platelet count anywhere near 10. So I'm a little bit more conservative with a patient like that who, if I'm on the fence about whether to give them chemo with a low platelet count and they have a history of hemoptysis or a large centralized tumor, this might be the patient I'm going to be a little more conservative and say, no, I'm going to hold your chemo. I don't want to risk that bleeding. And I'd be remiss if I forget to say one of the best treatments for tumor direct hemorrhage is radiation. This is where radiation can be very helpful for these patients. It's one of the first things that we do. We're going to go in with radiation, shrink that tumor really fast to get it away from those vessels so patients stop bleeding. So that's one of the best treatments.
Absolutely. I think this is an interesting thing because not that we ignore sort of the actual geographical location of where someone's tumor or disease state might be predominantly located, but in this situation and others, we think of colon cancer and obstruction, things like that, but sort of the structural location and what it's near can have these very important connections to the type of symptoms that you need to be very mindful of. And so it sounds like you said, for some of these centrally located tumors, maybe very large tumors, all nurses need to have that awareness. And even if you're not part of maybe the clinic setting, and you're not working directly with that physician or that practitioner, maybe you're an infusion. Maybe you're not as connected to what their latest CT scan showed, but just having that information, sharing that information among the care team so that if these symptoms do occur in different locations or, in different settings, that there's that equal awareness and understanding of what that could signify. And so sharing that information among team members is really important.
Yep.
So you mentioned radiation as a treatment. Are there any other approaches to treating some of these risks for pulmonary hemorrhage?
Not really. I mean, once they're bleeding, you need interventional pulmonary immediately. And interventional pulmonary will come in and hopefully be able to cauterize something, or like I said, do a lavage in the rare case of alveolar hemorrhage. But a bronch, anything that, the interventional pulmonologist can do from a procedural standpoint or the radiation are going to be your best options. And then the only other thing, like I said, is the prevention. If they're on blood thinners at that point, you're going to stop them. Do you need to transfuse their platelets? And just minimizing risk of them developing low platelets in that setting of active hemorrhage.
So kind of broad final question is just general education that nurses need to provide to our patients, their families, their caregivers, just about their risk for pulmonary toxicities. What should we be teaching them? What should we be emphasizing?
I think just emphasizing, well, number one, know what your baseline pulmonary status is and be very clear on that. What is your pulse ox at your baseline? Is it low? Is it high? Because then you'll note the changes from that will be if they're 5% lower than what they were. So if they're at 98 and they're at 93, that's a big change. If they live at 92 and now they're at 88, that's a change. So know what their baseline sort of pulmonary function is. They should call if they're short of breath. The lungs are, shocker, a vital organ. So this is not something that's like a rash that they can wait until next week when they come in to show you. Anytime someone is having increased shortness of breath, they should call. And then the dry cough really is a hallmark of a lot of these things. So don't just assume because you're not bringing up mucus or that you don't have a fever that a worsening cough is not something to report. You should report that as well. And then, we can ask all of these other questions that you and I kind of talked about to really tease out what might be the actual problem going on. And then you pair that up with what treatment they're on. And that's how we will make our decision on what this could possibly be.
Great advice. Great points to remember for sure. Well, Beth, thank you again for all of your time with us today, sharing some more of your expertise on these pulmonary toxicities. So as we approach the end of our episode, we'll run through our quick fire questions that we like to use to help summarize and highlight some of the points we've talked about today. How can healthcare professionals evaluate their hidden or their implicit bias when they're thinking about maybe a patient who is at risk for pulmonary toxicities? Are they assuming something that we should be cautious of assuming?
I guess I would say for implicit bias is don't just assume because a patient has COPD or they were a smoker that they will definitely get this pulmonary toxicity and therefore you would not treat them properly or maximally. I guess I would say it that way.
What are some common misconceptions about pulmonary toxicities?
Is that everyone will die from them. Is one, but then the flip side of that is that they aren't that bad because they are that bad. So there's lots of things that can be done for them, but they are serious and should be evaluated promptly.
What's something about this topic that's not often discussed, but you wish people knew more about?
That it's a risk factor of multiple different types of treatment. I think people would think that pulmonary toxicities, if you're radiating the lungs, and yes, that makes sense. But just giving a chemical like chemotherapy can also cause pulmonary toxicities. Or like we talked about with the stem cell transplant, a pulmonary toxicity can certainly be a side effect of that.
Right. You don't have to have lung cancer to have pulmonary toxicities. I agree with that. What additional training or education do you think oncology nurses need to stay current on this topic?
I think this is something that of all of the 8 different pulmonary toxicities you and I have talked about over these 2 different podcasts, they're all very different etiologies and treatments. So we went everywhere from infection and good stewardship with antibiotics to pulmonary GVHD, which is going to happen, in your typically leukemic lymphoma patients, to diffuse alveolar hemorrhage, which is a very pulmonary severe toxicity. I mean, we went all over the place here. And I think that's what's the hardest part for us as nurses is it's not just one thing that's causing it. And there's multiple different ways to treat these things based on what their etiology is. So just continuing to educate ourselves on the different pulmonary toxicities and identifying is so important to identify what the cause is because the treatment's going to vary depending on what that is.
And finally, what are some additional resources that you recommend for patients that want to learn more?
I still think things like the American Lung Association and the American Cancer Society have great patient resources. So those would be probably the 2 best ones to look for pulmonary toxicities.
Well, Beth, thank you again. It's been great talking to you for a second time, reviewing some more of these pulmonary toxicities, and I've learned something new, and I knew that I would. So thank you for your time today. Do you have any final comments to share with our listeners?
I just want to thank ONS and Jaime for interviewing me. This is a great topic that has a lot of different angles that you can talk about. So thank you for having me and bringing attention to this.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.